Thanks, Lydia and Francois, for organizing this. And yeah, I guess the breast lump, it's one of like the most dreaded that then comes to the clinic. So the focus of this talk is, I just want to move this down a little bit. A palpable breast lump, obviously in a woman, can be a potentially serious lesion, and most people fear that it could be breast cancer, and that's why there is that quick reaction to then refer just anybody else to the clinic. And most palpable lumps will require some evaluation of some sort, and we'll go into which ones do require a full triple assessment and which ones maybe you might just then clinically assess and then reassure. And you'll hear triple assessment everywhere else. Sister Muriel touch on it, Liana's touch on it, and that is basically the core of the diagnostic breast clinic. And the first step is actually to confirm the presence of a discrete mass. And this is not throwing guns to anybody else, but we find a whole lot of referrals that comes and they've documented breast lump, and you go there, you can't find it, you ask the patient, they can't find it. So one of those kind of quick cheats thing is in the right upper quadrant of any other woman, it tends to be much more glandular, and that you're feeling, it's actually not quite a breast lump. And in postmenopausal patients, in your inframammary fold, it feels a little bit nodular, and that can also then be mistaken as a breast lump. And fortunately, the investigation of most breast lumps will lead to a benign diagnosis. So one of those that you can just then reassure your patient, but then obviously depending on age and what the lumps feels like, we'll go through that again. And a systemic approach is needed to avoid over-investigation that results in increased health costs and most of the time anxiety to any other woman who comes to the breast lump and referred to the clinic. So as an introduction, breast lumps are more common in general practice. More than 25% of the women will be affected with by the breast disease in their lifetime, and majority of them will come complaining of a breast lump. And most, like I said, they will be benign, with breast cancer only diagnosed in about 10% of those newly diagnosed breast disease. And we know that the risk of breast cancer increases with age, with about 1 over 204 patients, that is 0.449% chance of breast cancer in a woman in her 30s, and compared to 1 in 28 patients, that is 3.54% in a woman in her 60s. The risk of breast lump being malignant in adolescent is exceedingly rare. And the median age of breast cancer diagnosis most of the time will be in the 61 years or postmenopausal range. But then obviously any other breast cancer, majority of them will be then in over 40, the 40 age range, and that is about 95% of the patients. Majority of breast cancers tends to be sporadic, that is in patients without family history of breast cancer. But obviously when there is a strong family history and it's a first degree under the 40, that tends to then put you in a high risk. And a first degree relative who is premenopausal then puts you in a high risk category. Triple assessment, like we've said, it's a current gold standard where then a patient will then receive a clinical assessment, and I'll elaborate a little bit more into that. Imaging that has already been touched on as well, and then tissue biopsy. And that all together can give you at least a diagnostic accuracy that approaches about 100%. So that's what we recommend. And it projects poorly on the screen, but this is basically the history and clinical examination. And if you have then referred patients to our clinic, you're probably then familiar with this sheet that we use. We've kind of taken away all the other risk factors that you might actually then miss. So this comes as a standard template in our clinic, and everybody else basically kind of follows the same questions and then stratifying the risk factors like they've already explained. So you want to know the age of your patient, if they are male or female, and then you go into the history of the breast lump and how long has it been there? Is there an associated nipple discharge? Is the nipple discharge bloody, or is it serious? Is it clear? Is it when it's expressed or then spontaneous? Obviously, then the one that would worry will be a spontaneous nipple discharge that is bloody and then unilateral. The ones where it is bilateral, it's milky and on expression, most of the time it is physiological, and then that doesn't really warrant like a further investigation. And more details then into the breast lump. Is there any associated inflammation with it? Is there maybe an abscess collection? Did you get treated with antibiotics? Did it resolve? And all those things. And you want to know if your patient is pregnant, if they're breastfeeding, and you also then go into the menstrual cycle as well. And if the history of the breast lump fluctuates also related to the menstrual cycle. We do see a lot of like mastalgia, and I'm sure the next speaker, Dr. Francois, will then speak about mastalgia more into detail. But I can then assure you that most of the time breast cancer does not present as mastalgia. And in very rare cases where there is focal mastalgia, then we can then start investigating as for breast cancer. But just as a bilateral mastalgia, that tends to then be cyclical or physiological. And then you want to then go again into the history of the previous breast history, if this person has been diagnosed with breast cancer before, if they've had any imaging that is suggestive of any previous pathology before, or if it was normal a couple of years ago, and if they've had any operations or any biopsies done. We do find a whole lot of patients that have had maybe breast augmentation or reduction where they've shifted tissues. There is some fat necrosis, and that can then present as a breast lump. And that sometimes then can cause a little bit of like anxiety in a patient thinking that it is a new breast lump that can then be mistaken for a breast cancer. And then we go into details now with the family history of breast cancer, and whether then it is any of your first degree relatives, any of your grandparents, your aunt, cousins. And that information, we use it to basically stratify your risk. And what we then tend to do in the clinic, there is a risk calculator that uses the Tyler-Kruzik method. We usually call it the IBIS Iconopedia, where you can enter all those information and it gives you a risk stratification for an individualized patient. And the figures that we do get will be at the back of this template, where if you get a risk of under 17%, basically that risk is almost equivalent to somebody else out there in the population, and that is not an increased risk. And you can basically assure that patient if the lump that we're investigating, it is not cancerous, and then you can discharge that patient. And then any risk between 18 to 25 to 30, then that puts that patient in a moderate risk. And depending on how the lump that we're investigating or that risk, basically you can then choose to then put that patient in some screening progress or surveillance programs of some sort, where you can then do repeated imaging. But we don't really have the resources to then image those patients every other year or 2 years. So what we then do, we take much more time teaching them how to properly do their self-breast examination so that they can then separate what is then pathological and not pathological. But if there's anything else worrisome, they can always then come back to the clinic for us to then check it out and then investigate further. And then anybody else then with a risk of more than 30%, obviously then their lifetime risk of actually getting breast cancer is quite high. And those are the patients that we keep in the high-risk clinic. And we probably then have to then refer them to genetics as well to then further then stratify or then do some genetic testing if it's required. And then we also then look into other histories of related cancers, whether then it is ovarian cancer, whether it's colon cancer, pancreas cancer, prostate cancer. And as some of these are actually then, patients who have other than BRCA1, BRCA2, they can have the P53 mutation, your PALB2-3 mutations, and that over a lifetime then can actually increase your risk of breast cancer way higher, more than the 30% that we've spoken about. And then we look into the exogenous or the menarche of your patients and whether then they're actually taking any exogenous hormones that can then increase the estrogen window. You will look into the menarche. Are they menopausal? Are they using any contraception? Are they postmenopausal? Are they using HRT? And some of all that information will then obviously increase your estrogen window and estrogen exposure, which can then increase your risk of breast cancer. And also then your past medical history, in case we're going to be operating, we need to know where your baseline is, and other risk factors like smoking, alcohol, and obesity that can then predispose you to breast cancer. And then when we then come to clinical examination, it's quite important to actually position your patient properly to then make sure that you are then not missing anything else. So inspection of the breast first needs to be done with the patient sitting and supine. You have to do a thorough observation of the overall breast size, shape, symmetry, nipple size, texture, and color. And when you actually then examine your patient in the supine position, it is best that they are laying down with the ipsilateral hand behind under their head. And you can use there's different methods on how you can examine the breast. So the tip is to not use the tips of your fingers, but then to use the finger pads. I'm not sure if you can actually see me. Use the finger pads, and that's where you actually get to then get the true consistency and the character of the breast and the glandularity. So if your hand is almost in a cup position, and you start either then concentric, making sure that you do not miss any part of the breast that is not examined, or you can go in the concentric or any wheel pattern. Any of them, it's fine, as long as you are consistent and that's what you then use all the time. And to assess whether then the mass is actually adhered to the pectoral muscle or the chest wall, you can ask the patient to sit up with the hips squeezed inwards, and then see if actually then the mass is mobile or immobile. But this will subjectively then be assessed then via CT chest if that is indicated. And do not forget to then assess for the lymph nodes. So your axillary lymph nodes, your cervical lymph nodes, and your supraclavicular fossa should be evaluated. It is a little bit difficult in especially assessing for the axillary lymph nodes in a clinical population, but give it your best. And if you can't, then we rely on the ultrasound to let us know then if there are any pathological lymph nodes. And then imaging, that would be then the second step, or not necessarily in that order. And the radiological assessment is quite critical, and it can consist, like the previous speakers have already spoken, either mammogram, ultrasound, or both. And the MRI can sometimes be used, but this is usually then referred for the specialist that is then treating those patients. So most two cases that are quite common that you can actually then request for mammogram will be in a follow-up of patients that are high risk with dense breast tissue as part of a surveillance program. Like I said, if they've got a very high IBIS risk factor or strong family history, and you are going to then continuously screen them, and you can't see on mammogram what the rest of the breast looks like. And then sometimes when you're trying to obtain more information in selected patients that have been diagnosed with breast cancer. So, for example, patients who've got lobular carcinoma that needs wide local excision, and you need to then assess the rest of the breast, or maybe elderly patients with Paget's that just then needs a wide local removal of the nipple areola complex, and they want to preserve the breast. So you need to then make sure that you're not leaving anything else behind in the breast. Or some patients where then the clinical exam and the mammogram is not quite in fitting, and the size of the lump, it's then a little bit incongruent. So you can then request for an MRI, but that we reserve it for almost an MDT discussion when we're then planning for surgery. And then, like we said, it is not cast in stone, but younger patients that we're talking about 30 to 40, where their brains are still very dense, the modality of choice will then be an ultrasound. And this is actually very accurate in distinguishing between benign and malignant breast lesion, because it's not hampered by breast density. So it's quite a tool to actually learn. And I've seen quite a few referrals from GPs that are actually doing ultrasounds in their offices, which is good up for them. And then fibroadenoma is actually quite common in young women, and an ultrasound has a sensitivity of about 82% with a specificity where it can rule out if there is no disease there, of about 95% in making the diagnosis. So if you suspect that your patient has a fibroadenoma and you've done an ultrasound and it looks like a fibroadenoma, you are probably right based on the ultrasound features. And then above 35 to 40, the mammogram will be the modality of choice, and sometimes then with an ultrasound use as an adjunct, depending on what we're then investigating. The disadvantage then with the mammogram is that it's less sensitive in dense breasts, and sometimes then the machines that we use, they've got what we call a tomogram, where you take multiple mammogram in slices and at different angles, and it almost looks like a CT scan, and that can assist in then diagnosing breast cancers. And sometimes when the lesion is a little bit too small, they can do what they call a spot compression, where you just then focus on that lump to then clearly identify it. But then the radiologist who works with the breast, they will then have an idea on which one to then, request as a follow-up. So it's not like you book a mammogram and the patient comes for the mammogram and then it comes back as inconclusive. They will try to then get to like the final of the diagnosis of the imaging of the lump at that point in time. And just bear in mind that 10%, a mammogram does have a 10% false negative rate. So if it comes back and your patient has a palpable breast lump and the mammogram, it's normal, you have to then take a step back and actually then investigate further, probably for further managing. So just don't be fooled and then reassure your patient that they are fine. And then these are just pictures of a mammogram. The one on the left, that is two breasts on a craniocaudal view, and their density on the side, then that's what breast cancer looks like. We look for a dense mass on the mammogram, and then this is actually an elderly woman with less dense breast, so you can actually see that lesion quite well. And then in the younger patients, or when we're using an ultrasound as an adjunct, we do ultrasound in the clinics, but then some of them can be done then at this radiology department. A cyst would look like a hypoechoic lesion on the side. It's quite smooth, well circumscribed with no posterior shadowing. And then fibroadenoma, this is what we'll probably diagnose most of the time. It's hypoechoic. It is not as hypoechoic as a cyst. It's got like some solid component into it. It's well circumscribed with no posterior acoustic shadowing as well. And then what it looks like totally different to a cancer, where then a cancer will be hypoechoic with some irregular margins. It tends to be taller than wide, and you then do see this posterior acoustic shadowing. And sometimes you then feel what feels like that breast lump that I've spoken about, but then it's just mainly glandular tissue, and then this is hypoechoic. But this is for the radiologist to then kind of play around and then figure out which one it is. And then once we have then done the imaging, we use the BI-RADS system to then report on where your patient then lies. And this is actually designed to then tell you what the final description is, what the recommendation is, and then what further action needs to be done. So BI-RADS 0 will be a patient where there is incomplete assessment and they've either done one modality and then it's you can't really comment on that lesion, and you need to then order and edit imaging, whether then it's going to be an ultrasound and less commonly an MRI unless then a specialist is involved, and that you can discuss with the radiologist or the treating surgeon what further views to then do. And then a BI-RADS 1 will then be a completely normal examination. There is no malignancy that's expected, and then you can discharge those patients. A BI-RADS 2 will then be a benign finding that is then reviewed and assessed by radiologists. There is no malignant potential there, and you can then discharge those patients. Then when we start going into BI-RADS 3, we're talking now where there is probably a benign finding, but some of the features are not quite benign, or you want to then actually repeat the imaging again to then call it benign. And this carries about a 2% risk of malignancy. So what they would then recommend is probably a follow-up examination in the interval of roughly 6 months. And you can then extend that to about 2-year follow-up. And at some point, it cannot remain as a BI-RADS 3 forever. Once it's being looked at before, there is no change in character, no change in size, and it has stabilized, then it gets upgraded to a BI-RADS 2, and then you can discharge those patients. And then when it gets to then a BI-RADS 4, then this becomes a little bit of like a complex situation. I haven't broken it down, but there's like 3 classes there where there's a BI-RADS 4A, 4B, 4C. And depending on the character, what it looks like, there is some potential that it could be a malignancy, but they will call it, and what then needs to basically happen, there is an intervention that's needed. And these are the patients where then you will have to then do a percutaneous needle as a core biopsy to establish what the histological pathology is. And they will then be referred for an ultrasound guided biopsy, and then it will then come back and assist you what the diagnosis is. And sometimes then they might need repeated imaging to then come to the conclusion. And then most of the patients then with breast cancer will then come, like the previous mammogram that I've shown, there will be a BI-RADS 5 lesion where the risk of malignancy then varies anything from 95 to 100%. And this then needs a core biopsy to then confirm that it is a malignancy. In the clinic, what we do is, because we see quite a lot of patients, if it is a sizable palpable mass, we go freehand core biopsy first. And if that biopsy comes back and it's inadequate, we will then not repeat it freehand, but then we'll do an ultrasound guided biopsy to then make sure that the turnaround time is quite quick. And this will then be referred for a biopsy, and then depending on what the pathology is, and then referred to the MDT for a treatment plan. And then BI-RADS6, you can see it if somebody has started in, let's say, with a biopsy first before imaging, and they already are known with breast cancer, or this is somebody with breast cancer who's going through chemo first, and they are then imaging at a later stage. So this patient would then have had a biopsy with a proven cancer, and they are just basically then waiting for their treatment plan. So when you then get an ultrasound report, for those that then request mammograms or ultrasound straight with the radiology department, and this can basically then guide you on what the next follow-up plan is. So the biopsy, I'm going to just go through this quickly. We used tissue biopsy has changed over time. In the past, it used to be an excisional biopsy in the 1960s, and it moves now to fine needle aspiration cytology, which we no longer recommend, to ultrasound guided core biopsy, which is now in the mid-90s. And the golden standard, we did say that it's a core biopsy. It does, Dr. Rood has then said, it will confirm the histology diagnosis. And on top of that, it gives you then the immunohistochemistry that it is then needed for you to then treat. And unfortunately, because South Africa is resource restrained, we cannot send anybody else or everybody else for ultrasound guided biopsy. But our rate then for freehand is still quite adequate, like I said. And then if it comes back and it's not conclusive, it doesn't match the clinical picture, then we will then refer then for ultrasound guided biopsy. And we do understand that some centers still do fine needle aspiration cytology. It is probably what is available out there in the clinics, and sometimes they use it just to fast track to then get the patient in the clinic. If you feel like it's going to actually not add more time, it's okay. You can then just send the patient, we'll then do all the core biopsies at our clinic. But we do need a confirmatory core biopsy with histology before we can then start the treatment plan. So with everything else that I have said, it can get very confusing. Not every patient then needs triple assessment, as the risk of breast cancer increases with age. And unfortunately, South Africa doesn't really have any stats in the adolescent, but the American Society from 2012 to 2016 did report the incidence of about 0.1 to 100,000 of adolescents having breast cancer in the US. And we're talking about 1 in a million here. So sometimes then the need to not over-investigate is quite important. So that's where then the age-based approach then comes in. So if you're seeing somebody, or we are seeing somebody else as an adolescent, and we're talking about the under age of 20, we know that the most common breast lump will be a fibroadenoma. And we can confirm that with an ultrasound in the clinic where we then do them. We are all both in training. Francois is probably the expert training everybody else. And I think that's probably then the future to go. And once it's confirmed the fibroadenoma, you can then just then reassure the patient there isn't much that needs to be done. Only the fibroadenomas that are more than 5 centimeters, these are called giant juvenile fibroadenomas. These are the ones that have the common indication for surgery. Everything else that is less than, usually they're about 2 to 3 centimeters. You don't need to do anything else about them. And then other differentials that can be there can be a cyst or a hematoma. And a hematoma is basically abnormal cells that grow in the area where the tissues originate, and they almost cause like a malformation. It can present as a lump, but they are benign and they're not cancerous. And sometimes then fat necrosis or an abscess. And then in this category, like I said, breast cancer is very, very rare, but you can then find other malignancies like a lymphoma or sarcoma, which are extremely rare, but they will present like a sinister lesion with a rapid growth. And the red flags for this one will be any other person with a history of breast cancer, especially if the family member is under the age of 40, with an irregular mass, and there is some skin erythema and some tethering, a bloody nipple discharge, retraction, or a rapidly enlarging mass. So when you then see these red flags, those are the ones that you actually then need to then refer to the clinic, and then they warrant a triple assessment. But anybody else with the typical fibroadenoma, 2 to 3 centimeters, you can reassure them and then discharge. If you choose to then follow them up, you just then need to do them once, at least in about 6 months to a year, to then document that the size hasn't changed, and you can then discharge those patients. And then when we move then to the second group, 20 to 25 of age, the fibroadenomas are still common again. Differential then probably will still be the same, but then you tend to then get much more of inflammatory breast conditions in this. You'll still have the cyst and the hematomas. although extremely rare, you can start seeing then breast cancers in this age categories. We do have a few of our patients at the age of 25 that are diagnosed with breast cancer. It's quite heavy, and you need to then make sure that you've actually not missed anything else there. And if the lesion is solid, typical appearance on fibroadenomas in this category as well, you don't need to biopsy them. You can then reassure them, and only after the age of 25, only then do you need to biopsy, just to then make sure. And their follow-up is exactly the same as well. 6 months, ultrasound, and then if it's stable, you can discharge them. And there is no need to remove any fibroadenomas that are under 5 centimeters, unless it's a small breast and it's filling up, like, you know, over 50% of like the female breast. And if there is suspicious features, then it warrants a core biopsy as well to exclude breast cancer. And then the indication for referrals with this ones will be exactly the same. Any red flags that are suggestive of breast cancer, fibroadenomas that are more than 5 centimeters. And if a patient requests then a fibroadenoma under 5 centimeters, we have to then weigh those risks, but then we can then grant them that if they do choose to, because sometimes they get tired of actually surveilling them, and then they will tell them that they don't know when it's actually grown or changed. And then over the age of 25, that's where we start then getting a little bit serious. You don't just ignore them. The breast cancer increases in this age. We recommend that everybody else over the age of 25 then goes through a triple assessment. Fibroadenomas are still common. It feels like that's like the send home message here. But between the age of 25 and 30, but the safest and the most straightforward approach here will be to remove any other lumps in any woman over the age of 30, because surveilling them becomes very tricky. And when we remove those lesions, depending on the size of it, we usually do it at what we call OG10, which is on a Monday. We do them under local. They come in, they don't need to then go through a GA, they're not fasted, and we just then inject local in that area. We remove it, and then we'll follow them up at the telephone clinic just to then confirm their diagnosis and that their wounds have healed. And if you do not remove them, or the patient wishes to not remove them, you need to then follow this up for at least about 2 years to then document that they are stable. And the indication for referral, roughly the same, between 25 to 30, any palpable lump who requests a removal. Over the age of 30 years, we recommend that everybody else then do refer. Or if it has then red flags, then we will diagnose breast cancer, and then we will refer them. So in a nutshell, you've got a palpable breast lump over the age of 20, you do a clinical exam, it comes back as a fibroadenoma, you can then reassure this patient and discharge. But then if it's got red flags, rapidly growing with atypical clinical exam or mass over 5 centimeters, and then you can then refer them for surgery. And then 2025, roughly the same thing. So this one's everybody else will then get an ultrasound, and then anything else that has red flags then gets referred or biopsied. And over the age of 25, it's a clinical assessment, ultrasound of everybody else. Mammogram, if you are over 35 to 40, we biopsy everybody else in that age, and we remove all lumps over the age of 40. If you don't remove them, follow it then for 2 years. And then if it comes back and it confirms a breast cancer, then they come to our clinic. And that is my conclusion. So the breast lumps are common. They cause significant emotional stress for the patient when detected. And you want to then just not refer your patient. We come with patients who are so scared, and you find it, a 15-year-old referred to the clinic and it's like, oh, I think it's a breast cancer. You know, when you refer them, maybe then just be careful and then say, I think, you know, they must just go then do all the relevant examination before we can then actually give you the diagnosis. And the website has been given to the clinic, and if there is appropriate referral, we will see it at the clinic. Thank you.